Thank you very much, Dr. Carol. I would like to thank HIV-NAT for giving me a great opportunity to be a speaker today. I have about 30 minutes from now, right? And quick questions. But I have a lot of number of slides, so I have to a little bit hurry. So this is my outline: epidemiology, treatment of TBI, clinical manifestation, diagnosis, blah, 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 blah. And I will start with the first question. How many people living with HIV die with TB each year? Please vote. What do you think? Each year, how many people with HIV die with TB each year? 100,000, 200, 300, 400, or 500? All right. Somebody said E and D. The answer is about 400,000. This is the last recent study. And we know that the proportion of TB cases of co-infection with HIV was highest in countries in African regions. It's about more than 50%. But in Thailand, HIV-TB co-infection is about 15%. Treatment of TBI. So preventive therapy for TB in HIV infection is very sensitive issue in Thailand. So I will not pay attention more about this, but this is the guideline showing that include almost 10,000 patients found that IPT can reduce risks of active TB amongst TST positive 64%, but it can prevent TB only 14% among TST negative individuals. Therefore, the HS guideline recommendation that should treat LTBI in positive screening, either TST or IGRA, with no evidence of active TB, only positive screening TST or IGRA, and TB patient that has close contact with person with infectious TB. I mean HIV patient close contact with person with infectious TB. It's very good for LTBI. So, but before you have LTBI treatment, you have to screen symptom first. Any cough, any fever, any sweat, weight loss, or lymphadenopathy. Absence of any of these symptoms has 97% negative predictive value for culture positive TB, including with film chest X-ray. If normal, TB could be excluded and can treat LTBI. So before you treat LTBI, you have to be careful that the patient have this symptom or not, and film X-ray in every patient. The clinical manifestation of TB HIV. So we compare between the symptom between early HIV infection and late HIV infection. I mean CD4 less than 200. So early HIV infection is like the TB patient that's normal in the normal populations. It's very adenopathy is very common. Pulmonary, it's upper lobe predominant. Cavity can present, and extrapulmonary it's only 10 to 15%, and pathology would be granulomatous. But the late HIV is, I mean CD4 less than 200. The TST is always negative. Adenopathy is unusual. Pulmonary distribution is maybe miliary, lower lobe, or middle lobe. Cavitation is typical absence. And extrapulmonary is more than 50% and always disseminated, particularly in HIV patients. And pathology, rare to be granulomatous, it have a lot of abscess. And do you know that TB HIV is associated with smear negative? Smear it's negative up to 50%. Hemoculture TB may be positive up to 50%. And once again, chest film may be normal up to 20% in HIV, that's CD4 less than 200. So I will move to the diagnosis. So AFB smear microscopic, you know, AFB smear, it's the first specimen sensitivity is 50%. The second specimen increased by 11%. The third specimen increased by 2 to 5%. For the first morning sputum, improved the sensitivity about 12% than single spot. You know that sensitivity of smear T-time in HIV infection is very low, about 50%. That's why this is very, very impressive test. Anybody know what is this? Yes, gene expert. Anybody know gene expert? Please raise your hand in your institute. Please raise your hand. Okay, good. Thank you. This is very, very, very fast, just about 90 minutes. And you can know that the patient has TB and the patient have MDR or not. So this, I think that expert is very, very good in HIV patient, because I just told you that HIV patient is associated with smear negative. So if smear negative, but the patient clinical symptom like TB, but smear negative up to 50%, the doctor, the physician will hesitate to treat the patient. But using expert in HIV patient is quite more increasing you. So this is the meta-analysis showing that HIV positive overall the sensitivity is about 90%. And if we focus HIV positive, smear negative, culture positive, expert can increasing you 61%. That is very, I think it's very good matching now. Any data in Thai population about expert? So we do the prospective multi-center study that we did in Chulalongkorn University, Ladvithi Hospital, and Bamlan Radu, and just published in Clinical Infectious Disease this year. And we allow the patient, almost 500 patients, and the patient diagnosed 355 patients diagnosed poly TB, and almost 80% definite TB, it means culture positive. And the rest is probable TB, it means clinical diagnosis, but almost 80% culture positive. And the data showing that, I will show you this column. Use this is as a gold standard to diagnose TB, definite or probable, and 355 patients. The expert sensitivity is almost 80%. It's better than culture. And AFB smear is only 40%. And specificity is almost 100%. If you do the test only in the gold standard, only MTB culture, expert sensitivity is 90%. And PPV is also 97% as well. It's quite high. But if we focus on probable TB, it means culture TB negative, and probable TB, it means clinical diagnosis. Gene expert can increasing you about 40%. And if we focus on only smear negative and culture positive, I said that smear negative, the physician sometimes is hesitate to treat TB, so it may be delayed treatment. So smear negative and culture positive, the overall increasing sensitivity is 80%. If we focus on HIV patient, it increased more than 85% of sensitivity, and non-HIV is about 80% as well. And positive predictive value is 100% among every both HIV and non-HIV. Okay, how about the detection of rifampicin resistant of our cohort study? And it shows that the sensitivity is about 93%, specificity is 100%, and PPV is 100%. So actually, our study is very, very high sensitivity. Why? Because the paper for in New England Journal that's published in 2010, the sensitivity is lower than our study. Why our study has very high sensitivity of gene expert? Because we centrifuge sputum. Because we have small amount of sputum, that's why we have to centrifuge it. 60% we centrifuge the sputum, and so it's maybe the main cause why the sensitivity of expert is very, very high. And that's consistent with the finding from South Africa that centrifuge sputum can increasing yield of smear negative, culture positive, increase from 72% to 85%. So I would like to conclusion our cohort study and found that gene expert is very most cost effective for sputum negative patients and setting with high prevalence of rifampicin resistance, particularly in HIV patients. Early diagnosis of TB result in early treatment and implementation of strategy to limit spreading of TB. And sputum centrifugation maybe increase the yield of expert MTB and MTB lifetime. Okay. And I'm to be talking about the expert and extrapulmonary. You know that extrapulmonary, particularly pleural fluid, is very poor sensitivity. It's about 51% in overall pool data, and TB HIV co-infection is much lower. I mean, pleural effusion, the sensitivity is only 40%. And CSF is about 80%, but TB in HIV co-infection is lower than 80%, it's about 70%. But it would be better if you centrifuge the CSF. It will up from 67% to 72%. And adult smear negative pulmonary TB, the pooling data is 68%, but TB HIV co-infection is only 61%. Let me move to the another test. Please vote. What is this test? 1. Urine LAM test. 2. Urine PrEP test. 4. Urine amphetamine test. 4. Too easy. I don't want to answer this question. Hopefully you not. Okay. Oh, sorry. Please vote. Oh my gosh, somebody answer question number 4. Okay, thank you. Oh, nearly everybody correct. Yeah. Okay. This is urine LAM. LAM is mean lipoarabinol maintenance. Yeah, lipoarabinol. What is this? It is mycobacterial lipoarabinol maintenance is heat stable glycolipid. It's outer cell wall of mycobacterial. Right now, we can diagnose TB by using urine. LAM is an immunogenic virulent factor. Is released by metabolically active bacilli. It's filtered by the kidney and hence detectable in urine. And it's real high sensitivity in the patient that have TB in blood. Because you know urine is from blood, right? When the patient have disseminated TB or you think that the patient have hemoculture positive for TB, maybe it's the patient will have positive for urine LAM. So it is very simple. It's lateral flow assays. It's enzyme link like ELISA and concept like urine PrEP test. And done bedside only 20 minutes, you can know that the patient have HIV or not. TB or not, sorry. But you have to be careful because LAM, like glycolipid, LAM can be false positive because some bacteria can have LAM like glycolipid. Corynebacterium diphtheria, nocardia, streptomyces, and Candida albicans. So this can make the false positive of ULI-LAM. And this is the pool data showing that the lower CD4, the higher in sensitivity of ULI-LAM. If the CD4 less than 100, the sensitivity is up to 60%. And the specificity is quite okay, it's 90%. And among inpatients, it's about 54%. How about ULI-LAM data in Thailand? We just published another paper in International Journal on Infectious Disease about the ULI-LAM in HIV prospective TB cohort study in big city in Thailand. And we have 109 patients were categorized into 4 groups. HIV group, HIV negative patient with disseminated TB, HIV negative immunocompromised patient with TB, and patient with disease other than TB. So it showed that it's pretty similar to the previous study. It showed that the lower CD4, the higher in sensitivity, but it's quite it's a little bit lower than the previous study because its sensitivity is about 45% when the patient has CD4 50%. But the blue bar is HIV infection. The orange is non-HIV infection. The non-HIV infection, the sensitivity is very poor, so just only 15%. But the positive PDT value is quite high. It means that if the non-HIV patient positive for ULI-LAM, the patient should be TB because positive PDT value is 100%. And we also looking for the smear negative and positive MTB culture with and without HIV. And we found that HIV infected patient in smear negative positive culture increasing yield about 44% in smear negative culture post MTB. And another interesting that we found that ULI-LAM was associated with death in both overall in HIV infection and in HIV that CD4 less than 50% and p-value is significant. The blue bar is LAM negative. The orange bar is LAM positive. This is mortality. LAM positive mortality rate overall is almost 30% compared with 8%. P-value very significant. If we're focusing on HIV infection, we found that it's also higher in mortality rate among the patient have ULI-LAM positive. And if we're focusing on HIV that CD4 less than 50, this is more higher in mortality among patients with positive ULI-LAM, 50% compared with 5%. And p-value very significant as well. We are going to draw conclusion of our study that the ULI-LAM test is especially helpful in case where the smear is negative and it popularly TB patient and severely ill HIV infected patient. That sometimes the patient that's very ill, sometimes it's difficult to collect the sputum. The urine is very easy to do and just only 20 minutes. And it may increase the yield of TB diagnosis and may predict the mortality rate of TB infections. This is study in South Africa that's published in Lancet last year, and it's showing that ULI-LAM can associate with reduced death in HIV positive. They treat nurse to do the ULI-LAM. This is the randomized control trial. There is 2 arms, and each arm is about 300 patients. One arm used LAM, another arm no LAMs, and it's found that 8-year mortality is different. 21% compared with 25%. Absolute risk reduction is 4%, and adjusted hazard ratio is 0.8, and p-value is significant. Used LAM can decrease the mortality. This is randomized control trial, the largest randomized control trial. So therefore, the WHO recommend that ULI-LAM can use in the patient with had CD4 lower than 100 and are seriously ill regardless of CD4 cell count And urine lamp should not be used as a screening test because it's quite the sensitivity is not quite high. Let me move to the treatment and special consideration with regard to starting ART. When to start ARV? What is the most crucial effect time to initiate HEART after treatment TB? Please vote. Oh no, sorry. sorry. No choice. Anybody help me, please? Which is the most crucial effect time? One more time. What level of viral load? Level of CD4? Type of OI? Or organ of infection? I don't know. Which one? Please vote. The most crucial effect time to initiate HEART after treatment TB. Okay, great. One patient again. Oh no, okay. No. The answer is CD4. You are right. The most important factor that impact on the how hurry to treat ARV after anti-TB treatment is CD4. Because if CD4 less than 50, you have to prescribe HEART within 2 weeks, both the SS guideline and NTS guideline, except for TB meningitis. TB meningitis, you have to be careful, no rush. I will show you some there. Why? And this is why less than 40%, because it's the paper that's published in England Journal since 2011. Both 3 studies are our randomized control trial. It shows that the orange bar is early HEART. It's about 2 weeks after TB treatment and start HEART. The red bar is later, wait until 8 weeks, and it's showing that it's lower in mortality rate if you prescribe HEART within 2 weeks. And p-value is very dramatic, significant, decreasing in mortality rate. Why except for the patient with HIV infection and tuberculosis meningitis? Because there is this paper in Vietnam that published in CID last 4 years. And this is the randomized control trial and showing that immediate within 4 days versus deferred ART in patients with HIV-associated TB meningitis. And every patient prescribed standard anti-TB and adjunctive dexamethasone and prophylaxis Bactrim and follow up to 12 months. And it's showing that in each arm is about 120 patients, and it shows that immediate ART or wait until 1 or 2 months, it's not significant associated with 9-month mortality. So, but in the immediate HEART have the more side effects, 86% compared with 70%. This is grade 3 or grade 4, but if grade 4, it's pretty higher of adverse event. It means that the patient will become eyeless. And when the patient have eyeless of meningitis, the patient will become severe, and this patient will turn to be dead, easy to dead or easy to die. That's why they recommend that TB HIV TB meningitis we can wait until about 1 or 2 months and just start ART. This is recommended in clinical infectious disease IDSA guideline. They will wait until 8 weeks, but in my personally, I think wait until 8 weeks it's too long. The guideline in Thailand is about 2 or 4 weeks, not faster than 4 weeks. Wait until 2 weeks. Sorry. In my personally, I wait until 2 or 4 weeks and start HEART in TB meningitis. What to start ARV? This is pretty simple. The patient in HIV, TB, treat INH, rifampicin, ethambutol, and PCA. What is the best regimen of heart therapy? This is pretty easy. Oh, I have 5 minutes left. Okay, yes, the number one is correct. So I will showing you do that because rifampicin is the most important drug to treat TB, but rifampicin is cytochrome P450 inducer. It can decrease the level of ARV. Efavirenz level decrease 22%. Nevirapine decrease 50%. Lepidolin decrease up to 80%. PI more than 75%, and Lauticovir is about 40%. The best regimen is efavirenz base. Nevirapine decrease 50%, but anyway, should be avoided if possible, but if necessary, initiate nevirapine, but no need to be lead in. Lepidolin decreased very 80%, so you should be avoid. PI, I think you should be avoid too, even though they have some data that we can use, but I don't use it. Lauticovir, you can use it, but double dose. But there is some data that no need to be increased dose, in particular in Thai population, can be used normal dose as well. But Lauticovir is quite expensive. Therefore, efavirenz base is the best, I think. So, but rifampicin and PI can use together because rifampicin will not decrease the level of PI much, but you have to be careful. PI level, but it's PI will increase the rifampicin level. That it can increase the side effect of rifampicin is uveitis. You have to be careful. So the last one is manage of drug-resistant TB. So how many percent how many time I left now? 5 minutes, right? 10? Okay, thank you. So I would like you to know the term of ARR. ARR is acquired rifampicin resistant. It's a unique phenomenon complicating HIV-associated pulmonary TB. ARR is HIV co-infection has been reported. It's particularly in advanced stages of HIV, absence of heart, extensive and or disseminated TB, initial isoniazid resistance. Because acquired rifampicin, because in its in HIV patient have malabsorptions, maybe the rifampicin level in the blood is pretty low. That's why it can be have acquired rifampicin resistance in HIV patient. So this is the recommendation in treatment of MDR, this new guideline on in WHO last year. And I will show that they categorize the drug into 4 categories: Group A, Group B, Group C, and Group D. Group A is fluoroquinolone. Group B is second line injectable drug, amikacin, cafeomycin, garamycin, and core drug is ethionamide, acetylcholine, linezolid, and chlorphazamine is become a core drug now because in 2011 linezolid and chlorphazamine is not core drug, but right now linezolid and chlorphazamine become a core drug for treatment MDR, and PAS not a core drug anymore because it's very low potency. So the principle of treat MDR is 1, choose at least 4 drugs from Group A, Group B, Group C. You choose Group A 1 single agent, Group B 1 more single agent, and Group C 2 more, 2 compound to 4 drugs. I will prefer levofloxacin, garamycin, ethionamide, and on cyclosporine. But in just somebody cannot use ethionamide or have side effect of cyclosporine, you can use chlorphazamine or linezolid. But linezolid is very expensive and have side effect as well. And group B, second line injectable drug, you use more than 4 months after culture conversion and minimum 6 to 8 months at least. And total WHO recommended treatment duration is 20 months, almost 2 years. MDR-TB, you took 2 years, right? And linezolid can be used particularly in PXDR. Betacurine and dilamanid, it's a new drug. You can add to the regimen if toxicity or resistance in group A, group B, and group C. And single drug should not be added to a failing regimen. So, like a couple of months ago, one of my patients just asked me for treat him with shorter MDR-TB regimen. Anybody know that right now we can treat MDR-TB only 1 year? What is the nickname of shorter MDR-TB? Shorter MDR regimen. What is the nickname? 1, Cameroon regimen. 2, South Africa regimen. 3, Bangladesh regimen or Thailand regimen. Please vote. Because I think right now the patient have a lot of knowledge now. They ask me that can treat him with shorter MDR-TB regimen. Yes, Thailand regimen. Oh wow, interesting. No, actually it's Bangladesh regimen. Yeah, Bangladesh. Yeah. So the duration Bangladesh regimen is the treatment. Actually, MDR you have to treat 2 years, but this regimen treat only 1 year. Why? The principle is the Bangladesh have a lot of MDR patients, and the treatment success is only 50%. Why is only 50%? Because it take 2 years. The patient always lost to follow-up, right? So they try to mix like cocktail therapy, something like that. Intensive phase, they add moxifloxacin, chlorpheniramine, PZA, ethambutol, proteonamide, high-dose NH, and garnamycin. 7 drugs in the first 6 months, and follow with the continuous phase, moxifloxacin, chlorpheniramine, PZA, and ethambutol. High-dose NH, with if more than 50% prescribed NH 600 milligram, is quite high, right? So, and the paper showing that, I will show you some data, but HIV is not the contraindication for shorter MDR-TB. The HIV patient can use this, but they cannot use shorter MDR in the pregnancy patient because proteonamide should be avoided in pregnancy patient. And the patient have to be confirmed that not resistant to second line drug and not export at least 1 second line medicine for 1 month. And extrapolar TB is the contraindication because it still have lack of data. And it's very, very good. But I just to let you know that this is the just observational study. You have to wait until next upcoming 2 years in a randomized control trial. It's conducting. This is observational study from Bangladesh and Cameroon, and treat with this regimen and cure rate and complete treatment is almost 90%, and failure only 0.5%. And this study is the same things. Cure rate is 80%. In Cameroon, cure rate is almost 90%, and failure rate is less than 1%, and relapse rate is less than 1% too. That's why WHO try to encourage that. Why Thailand still not use shorter MDR regimen? So, but we are going to conduct the study, and this is the randomized control trial that is going to publish next 2 years that shorter MDR regimen is good or not. Okay, this is last 2 slides for take-home message. HIV patients are associated with smear negative, culture positive, and expert is increasing sensitivity about 60%. And in our cohort study, its sensitivity is over 80% with centrifuge sputum. Usually LAMS is used to assist to diagnose active TB in HIV positive, and it can predict the mortality rate, particularly in patient has CD4 less than 100. And the best regimen to treat TB and HIV co-infection is rifampicin and efavirenz-based, should be avoid PI. And ART should ideally initiate within first 2 weeks if the patient CD4 less than 50, except for the HIV infected patient with TB meningitis. At least MPR TB, the regimen should be at least 5 effective TB medicine during intensive phase, including BCA. Okay, and the shorter MPR TB regimen is quite promising. Just wait for the RCT trial in upcoming for next year. Thank you very much for your attention.